So, good afternoon, everybody, and thank you for taking time out of your busy day to join us as we focus on issues that are important to your heart. Specifically, today, we're going to talk about the importance of time, timing of identifying heart disease, timing of preparing to avoid heart disease, and what it means in terms of your overall outcomes. Hi, I'm Dr. Hal Skopicki, and I'm the Chief of Cardiology at Stony Brook University Hospital and also the co-director of the Stony Brook University Heart Institute. I'm joined here today by Dr. Robert Pio, Dr. Henry Tannous, and Dr. Eric Rashba, and I'm going to ask them all to introduce themselves and tell you a little bit about what they do at the hospital. Robert?
Hello, everyone. Very pleased to be here today and thank everyone for taking time out to be with us. My name is Dr. Robert Pio. I am the Director of Interventional Cardiology at Stony Brook University Hospital. I'm the guy that puts in stents, treat heart attacks. I do a few other things like treat valvular heart disease non-surgically. Again, I'm very happy to be here and very happy to answer any of your questions.
Dr. Rashba.
Hi, I'm Eric Rashba. I'm director of the Heart Rhythm Center here at Stony Brook and professor of medicine. So I'm a cardiac electrophysiologist. So we treat all electrical abnormalities of the heart. So that can be slow heart rhythms, fast heart rhythms, fainting spells. So we try to design the best medical treatment. We also do ablation procedures as well as device implants for heart rhythm disorders.
And Dr. Tannous?
Hi, I'm happy to be part of this conversation today, and I hope it brings more people to make the right decisions for their hearts. Here at the Heart Institute in Stony Brook, I lead a team of cardiothoracic surgeons specializing in procedures relating to the heart, lungs, and other organs in the chest. I'm also the surgical director of the Stony Brook Structural Heart Program. Happy to be with you today.
Well, thank you, guys. And I think everybody is really in store for a rather enlightening discussion. We're going to be talking about how to optimize prevention strategies as far as heart disease is concerned, trying to do that earlier in your life, kind of like when you put money into a retirement account so that it pays off later on in your lives. But we'll also be talking about why early detection matters, why your symptoms might be a clue to something that might be going on that we can intervene on early. And then we're going to talk about things that we do or that we're capable of doing in an advanced stage to be able to lessen your symptoms, improve your quality of life, and hopefully extend your life. During our discussion, I'm going to ask that you please take the time to type in any questions you might have in the comments section, and we'll do our best to answer them during this conversation. So if it's okay with our panel members, what I'm going to do is kind of go around and get some basic understanding of what their disease specialties entail. So Robert, if you wouldn't mind, could you tell our audience a little bit about atherosclerosis, how arteries kind of get cholesterol in them, when it starts to happen, and when it starts to become significant, what does a patient experience?
Right. So atherosclerosis is a process by which the arteries in your entire body, including the arteries that supply the muscles of your heart, develop plaques. And these plaques, as they grow, occupy more and more volume in your arteries, such as the coronary arteries that feed the muscle of the heart. And when the volume gets large enough so that it impedes blood flow, then you can have angina. And that is chest discomfort that arises because there's not enough blood flow to the heart muscle. Now, when these atherosclerotic lesions rupture and the contents of this atherosclerotic plaque which includes cholesterol particles. It includes a lot of, I don't know, for lack of a better way to put it, a lot of gunk. When that comes in contact with your bloodstream and a clot forms, that causes a heart attack. How do these form? Well, we're all born with clean arteries, and there's a lining of the artery that prevents particles from sticking on them. Particles like platelets, for example. These are little particles that circulate in your bloodstream, and their function is to really prevent bleeding. When you cut yourself. As we age, um, as we develop hypertension, what essentially happens, part of the process is that the lining of the heart that really protects these atherosclerotic lesions from forming, they sort of break down, and these breaks in the lining of the wall then causes ingress of particles, cholesterol particles, for example. And as the cholesterol particles come into the arteries, well, that sets up a cycle that incites inflammations. These inflammatory cells.
Robert, let me get this. So let me get this
Yes.
straight. So cholesterol is floating around in your bloodstream, bumps up against the walls of the arteries, and sometimes the wall lets it in, and sometimes the wall doesn't let it in.
Yes.
And so, what are some of the factors that determine if it gets in? Would things like high blood pressure or diabetes affect how much cholesterol can get into an artery?
Yes. So hypertension. So in a nutshell, disease conditions like hypertension, hyperlipidemia, diabetes, these disease conditions can cause damage to the lining of the wall, which then allows the ingress of these cholesterol particles. And with the ingress of these cholesterol particles, you incite an inflammatory response that then causes further damage to the lining of the wall, and further ingress of cholesterol particles, ingress of other cells, inflammatory cells, and basically the cholesterol lesion grows, and it
So
grows
it's
in.
important to attack those things early on in life. It's important to take care of the diabetes,
Yes,
get your blood pressure checked, and
yes,
make sure that your cholesterol levels are low.
absolutely, absolutely. So the risk factors for developing coronary artery disease, well, diabetes, as was mentioned, hypertension, hyperlipidemia, these are all risk factors that can be controlled. Now, there are some risk factors that cannot be controlled, which is genetics. Um, and that's what you're born with. But it's very, very important that the risk factors that you can control, external risk factors, are optimized so that this process that we just went over does not start.
So we'll get to how that evolves over time in subsequent questions. But needless to say, when you're in your 20s, 30s, and 40s, it's really important to pay attention to not put that cholesterol in early on and to do the things that keep blood vessels healthy. Turning now to bad rhythms and the heart. So, Dr. Rashba, you mentioned that you're the director of the Heart Rhythm program here at Stony Brook. Can you tell us about a couple of the more common presentations that you have in terms of when a patient should say, hey, wait a second, there might be something going on with my heart rhythm? What are the patients experiencing at that time?
So the symptoms to look out for are palpitations, like a fluttering heartbeat. Not everyone experiences that when they get a rapid heartbeat, though. Sometimes people have much more subtle symptoms. You may just not feel right. They can be fatigued or short of breath, have symptoms of congestive heart failure. And it's only once we start monitoring them or do an EKG that we realize, a heart rhythm problem may actually be the issue. The other symptom to be aware of is dizziness or blackout spells. Often these get attributed to, like a neurological or brain problem, maybe like a mini stroke, but If your heart's not pumping and getting blood to your brain, that's the most common cause of actually blacking out.
So one of the things that we're constantly asked as cardiologists is, you ask a patient, do you experience palpitations? And the patient gives you this blank look of what's a palpitation? Can you kind of put that in layman's terms? What should a person be looking for in terms of palpitations?
Racing heartbeat, fluttering in the chest, just a strange sensation in the chest. Some people just call it a rumble, is what they'll describe to me.
So ordinarily, people don't notice that their heart is beating. In fact, it's kind of in the background, and you shouldn't be aware that your heart is beating. But when you start to notice that it is beating and it feels irregular, or that it feels like it's going very, very fast, that all falls under the term palpitation?
Yes. Any rapid or irregular heartbeat, anything about your heartbeat that feels abnormal. Some people may just be too sensitive to the normal heartbeat, though. So if you have like a normal pulse rate, we all have these newer watches and devices where we get more information than perhaps we might want about our heartbeat. But, if your heart rate is normal, if you're monitoring it, say with, an Apple Watch or one of these devices, and it seems regular, that may not actually be a problem. But if you feel irregularity or very rapid pulse rate, that's something to
Okay.
check out.
And another thing that people run around or their doctors have told them is that they have something called atrial fibrillation, or AFib. Can you give us a one-sentence description of what AFib is all about and what we should be looking for in terms of symptoms?
Yeah, so AFib is the most common arrhythmia. So it's more common as you get older. For seniors, almost 1 in 10 people have it. So it's an irregular heartbeat that comes from the left atrium, the left upper chamber of the heart, right where the veins that drain blood from the lungs hook up to the left upper chamber of the heart. So those areas have heart muscle that's electrically overactive and can trigger the arrhythmia. So normally each heartbeat comes actually from the opposite side, the right side of the heart, at an area called the sinus node, which is the heart's natural pacemaker. When you're in AFib, it just fires, these other areas on the left side fire very rapidly and abnormally and can make the heart race. Several implications when it beats rapidly and irregularly. The blood flow is slower, more sluggish, and there can be a risk of clots forming in the left upper chamber of the heart, which can cause stroke. And there are also other considerations to slow the heart rate down or prevent.
So we'll get into that management in a second. So what you're saying though is that irregular heartbeat, that atrial fibrillation, can have some very serious consequences and needs to be dealt with by somebody who can guide the person to really good outcomes. So time does matter.
Yeah, I think we'll have time to talk more about this later, but especially with atrial fibrillation, intervening early in the process matters. It's much easier to treat. When people are diagnosed early, if you've had it for years and you're stuck in atrial fibrillation for 5 or 10 years, it's much more difficult to treat. So early on, people tend to have brief first episodes that stop on their own without requiring medical intervention to get the rhythm back to normal. As things progress, the episodes can be longer and actually require either electrical cardioversion, where we shock the rhythm back to normal, or we convert it with drugs chemically.
Right.
As things get more established, they're more difficult to treat either with medication or procedures. So definitely recognizing it early and treating appropriately makes a big difference.
Right. And so in general, for heart rhythm disturbances, when the heart is beating, you're noticing that it's beating very fast, or you know that it's beating very irregular. Would you say that lightheadedness would be one of those things you really should kind of run over to the doctor with if you're noticing your heart beating irregularly? And would you say that chest pain might be another symptom to kind of really seek out attention quickly before things get too out of hand?
Sure. So those may or may not be, symptoms of a heart rhythm problem. Obviously, chest pain, we have to make sure it's not in Robert's alley in terms of a blocked artery, but some people don't sense a racing heartbeat, particularly with atrial fibrillation. For whatever reason, people can have their heart racing quite rapidly and not be aware of palpitations per se, of fluttering in the chest, but they might have chest pain because it's making the heart work harder. They might feel short of breath or dizzy. So the symptoms can be subtle. It may not really be obvious to the patient that it's the heart that's the issue, or that it's the heart rhythm that's the issue. So definitely seek medical attention if those things are going on.
So let me turn it now over to Dr. Tannous. Dr. Tannous is the person that you are incredibly grateful to be seeing if somebody tells you that something requires surgery, but he's also the person who's going to look at things and try and decide, is there another way to go about this? So, Henry, if you wouldn't mind, tell us about the two types of patients that come in to see you. The one who has blockages in their arteries, and also secondarily, the ones who are told their valves might not be working the way they need to be working.
Okay, well, thank you, Hal. Here at Stony Brook Heart Institute, we pride ourselves with the variety of procedures that we can offer patients. We do a couple hundreds of coronary bypasses surgeries a year, and we do a couple hundreds of structural heart cases a year. Just to define it, a structural heart specialist focuses on the valves. A valve is like a door between two chambers of a house. We want blood to flow forward, so the door has to open. We don't want blood to flow backward, so we want the door to close well. If the valve is not opening well, we call that stenosis, and if the valve is leaking, we call it regurgitation. So it's important to differentiate between the two pathologies. We want blood to be able to exit the heart, and if the aortic valve is not opening, we call that aortic stenosis. While I surely hope our audience will never need a surgical procedure for an advanced heart problem, I can tell them the good news that in the past 10 years there have been tremendous advancement in this field to improve patients' recovery, outcome, and quality of life. But early detection is key, and close monitoring is key, because sometimes the symptoms might be minimal.
So let me kind of now go back and let's start talking about different ages of life. So Robert, would you say in your 20s and 30s, it really is all about prevention? And how does somebody in their 20s and 30s know that something might be up and they might be one of those people who are experiencing a blockage in their artery earlier than most?
Typically, it's unusual for somebody in their 20s and 30s to present with symptomatic heart disease. I mean, heart disease is, of course, a very, very broad category. So, for the sake of discussion, I'll say coronary artery disease, or blockages in the blood vessels that feed the muscle of the heart. I'll speak on that. It is very, very unusual for somebody in their 20s and 30s to present with symptomatic heart disease. And the fact that you're symptomatic, what that means to me is that, we're blessed with bodies that have tremendous reserve and a tremendous way of normalizing or compensating for a disease that is happening. So when you start having disease, that means that the disease, in my point of view, has advanced to the point that your body's compensatory mechanisms has failed. And for that to happen in your 20s and 30s is rare, because you need time for some of the risk factors we talked about earlier in our discussion: hypertension, for example, diabetes, high cholesterol. We need time for these disease processes to, do their bad work on your arteries before your compensatory mechanisms fail. And also the onset of some of the risk factors, such as hypertension, diabetes, and hyperlipidemia, they occur later in life. So it would make sense, however, that there are some patients who experience or have onset of some of these risk factors earlier in life. For example, if you are somebody that developed diabetes in your teens, what we call type 1 diabetes, then you could be one of these people who are extremely high risk for developing what we call really premature coronary artery disease or coronary artery disease in the very young. So these are people who may be in their 30s who develop coronary artery disease that are symptomatic. If you have bad genes, that's that's another risk factor that would dispose a very young individual to symptomatic coronary artery disease. I mean, if you have a family history of multiple immediate family members, especially your mother, father, for example, who have had a onset of disease when they were very, very young, then you could be predisposed to developing coronary artery disease at a very young age.
So take us through that, Robert. So a person goes ahead and they have a family history, they're a young age, and all of a sudden they say, maybe I'm having some chest pain or pressure. Could this be that one of my arteries is blocking up? Should they seek a cardiologist's attention at that point? Should they go to their internist? What's the next step? And then what would you expect to happen from that moment?
So I think it's reasonable for a very young individual. Again, it's because some of these symptoms that such as chest pain or chest pressure, for example, I mean, whether these symptoms are symptomatic or specific or non-specific, or the consideration of these symptoms as specific or non-specific, precisely, it really sort of depends on the patient. So if it's a very young patient that comes in and says that I have some chest discomfort, let's say somebody in their 20s versus somebody in their 50s that has the exact same symptoms, the implications may be a little different. However, they should not be ignored. So for the very young patient who is otherwise physically healthy, doesn't have type 1 diabetes, doesn't have a really bad family history of premature coronary artery disease, and has some chest discomfort, well, I think that and these symptoms are not severe, I think a visit to a family medicine doctor is a reasonable. And then at the family medicine doctor, I think some of the things that he's going to be looking at is, okay, can I identify risk factors for this patient? So you'll get a blood pressure check, make sure your blood pressure is under control. He may draw lipids to make sure that you're not one of these people who have familial hyperlipidemia in which your cholesterols are, you're genetically prone to have very high cholesterol. And he may check for, depending upon what your other symptoms may be, a test for diabetes so that he could identify, do you have risk factors for having coronary artery disease? And then depending upon that initial assessment, he may then send you to a cardiac specialist if further workup is needed. Now, there's one important caveat. I think regardless of your age, if your symptoms are severe, and these are symptoms, and you have recurrent symptoms, and if you have recurrent symptoms and one day you say, God, this is something that I have never felt before, I've never had this kind of intensity of chest discomfort before, I think you need to go to the emergency room for a immediate evaluation.
Very, very, very good and strong advice that if you're feeling something you haven't experienced beforehand and it feels severe, don't waste time. Get to the emergency room. If it's something that's a little bit more chronic or that you've been living with, getting it checked out earlier seems the thing to do. Robert, just as an aside, what's the youngest patient you've ever seen with a blockage in their artery?
That occurred at Stony Brook University Hospital, and this was somebody who was in under 30. I want to say, I can't remember exactly, but I think the patient was about between 25 and 27.
Okay. So moving now on, so I think we've kind of drilled into the fact that if you're experiencing symptoms, chest pain, pressure, shortness of breath, anything along those lines, and specifically if they occur more with activity, when your heart is being asked to do more, those are kind of some of the warning signs that you might be having a blockage in your artery. So let's move it over to Dr. Rashba. When we talk about different types of heart rhythm disturbances, could you tell us a little bit about rhythm disturbances that occur in the top part of the heart versus the bottom part of the heart? Which ones may be more dangerous and which ones can give you symptoms?
Well, all of them can give you symptoms. In terms of which ones can be more dangerous, that would be the bottom, not the top part of the heart. So I noticed a question came in about sick sinus syndrome. So as we briefly mentioned before, the normal pacemaker area of the heart is the sinus node located in the right upper chamber of the heart. So normally it beats regularly, increases with activity, decreases when you're resting. Sick sinus syndrome is when that area just doesn't fire when it's supposed to. So all of a sudden, instead of a regular heartbeat, it'll just stop. And what that can cause is a pause in the heart rhythm, dizziness, or fainting. So typically that is treated with a pacemaker unless the patient is on medications that could be causing the problem, in which case, if we can, we would try to stop those medications. Other abnormal rhythms from the upper chamber of the heart. So we see a lot of younger patients in electrophysiology that have an arrhythmia called SVT. So that is caused by an extra electrical circuit in the heart. So instead of just starting in that sinus node area, traveling through the normal electrical system down through the center to the bottom, those patients have an extra electrical pathway. So instead of going top to bottom, the electrical impulse can ricochet back up that extra pathway and cause a very rapid heartbeat. It feels terrible to the patient when their heart rate's going very fast, but it's actually not dangerous in most circumstances. One of the more satisfying things we do as electrophysiologists is ablation procedures, particularly for SVT. We can introduce IVs into the vein at the top of the leg, put wires up to the heart, map out where that extra pathway is, and actually cauterize it with one of the wires to get rid of it permanently. So we have the opportunity to actually cure patients who have that problem.
So one of the real advantages of having an advanced heart rhythm program is you can make a decision about which heart rhythm disturbances need further investigation and which you can give reassurance. And the ones that need further investigation, you have the ability to bring them into the laboratory and help define what that bad rhythm is. Can you take our listeners through what it's like coming into the heart rhythm laboratory to have your bad rhythms dealt with?
Sure. We have a whole team. So we do all of our procedures with anesthesiologists, in most cases cardiac anesthesiologists. So they're very familiar with all the problems that we deal with. We have a team of nurse practitioners and physician's assistants who speak to the patient ahead of the procedure after they meet with one of the doctors to, again, reinforce what they can expect before they arrive so that they're comfortable with what's going to happen. When they enter the procedure suite, there's all our equipment's there, but they meet all of our electrophysiology lab nurses. So they're specialized RNs that are trained in electrophysiology, and they both monitor the patient as well as scrub in and help with the procedures themselves. So depending on what's being done, the patient can be either lightly sedated or under deeper anesthesia, depending on the needs for the particular procedure that they have. But it's a team approach, and everyone works to help the patient feel comfortable when they enter the line.
And so we have a question from Aaron who said, what causes the feeling of a strong heartbeat that you can feel it in your upper body and all the way into your ears, and you can actually see it through their clothing? However, when they take a look at the blood pressure, it appears to be normal, and maybe even the pulse is normal.
So some people are more sensitive to the normal heartbeat in terms of why. It's difficult to know, but often people who have this sensation may have skip beats, either from the upper or lower chamber of the heart. When they come from the upper chamber, they're called premature atrial contractions. From the ventricles, premature ventricular contractions. In most cases, those are benign, but the patient would not feel regularity in that situation. They'll feel like a skip and then a pause, and that can be bothersome to some people. Often they can be treated with medication, or in the case of premature ventricular contractions, skip beats arising from the lower chambers of the heart, we can treat them with ablation as well to get rid of them.
Right. And so kind of turning it back over into Henry's world. So let's say we have somebody who has a blockage in one of their arteries, and they're trying to figure out, do I go ahead and see if somebody can open this up with a catheter, or do I need heart surgery? Can you talk a little bit about why having a heart team approach and having a lot of different specialties in the room to discuss everybody's case makes a difference?
Sure. It's very important to have a variety of options presented to the patient, and sometimes those options are all viable options, and sometimes it's a clear cut one way or the other. When somebody has a lot of blockages in all three main territories of the heart, or if they're diabetic, the studies have proven over and over again that a bypass surgery is the right answer, and that will present the patient with a more durable and comprehensive solution to their problems. In some situations where a bypass surgery cannot be done because of other factors, we're lucky to have a cath lab that can handle those patients, and we will present those patients with a stent. But as we get older, there are a few facts. Just like as we get older, we cannot generate the same heart rate during exercise. As we get older, the vessels are stiffer, and with that comes hypertension. So even if somebody doesn't have high blood pressure right now, they should continue to monitor as they get older, because you'll never know when your blood pressure will start to rise. And that not only affects the heart, it could affect the brain, the eyes, the kidneys. And specifically to the heart, it could lead to blockages in the coronary arteries, like Dr. Payo mentioned, or stenosis of the valves. And if our audience right now, whatever, a couple hundreds are watching us, 5 to 6% of people over 75 will have an aortic stenosis. And if we can get the word out to get checked, because sometimes the symptoms could be mild, but they still need a close monitoring.
So let's actually, that's a good segue to start talking about valves and the different types of valve problems that we see. So Robert, I know that when I'm doing my general cardiology, I oftentimes see people who have problems with their aortic valve, and people who have problems with their mitral valve. As I like to explain to them, the aortic valve is that last valve of the heart where the heart has to push blood into the entire body. It's got to open up that last valve, and that there are two types of valves problems that occur that make it harder to open that door. Would you mind talking a little bit about a calcified aortic valve and a bicuspid aortic valve?
Yeah, so I think this was mentioned earlier by Dr. Tannous, that basically there's two sorts of general valve disorders, valves that leak and valves that don't open. So with specific to the problem that pertains to the aortic valve and the problem of the valves not opening. So calcific or degenerative aortic stenosis are attributed or associated with patients who are older. So this is a degenerative process that occurs over a long period of time in which the leaflets of the valves, which when you're born, I mean, they're very pliable, they're thin, they're smooth. With the wear and tear as you age, and there may be some other factors like hyperlipidemia, which may be implicated, these valves become stiff. And not only do they become stiff, the leaflets, which normally work independently of one another, well, they stick together, right? And they stick together. So you can imagine that these valves, and for the aortic valve, has three leaflets that work independently. And when they open, they should be free to open. But you can imagine that as they get stuck together, they're not going to be able to open as efficiently. And part of that process of the valve leaflets sticking together also involves calcification. So your valves develop calcium. So that is one type of aortic stenosis pathology. The other is a bicuspid aortic valve, or aortic stenosis that associated with bicuspid aortic valves. And normally an aortic valve has three leaflets. Some patients are born with leaflets that are bicuspid, in that there's only two leaflets. And because of the abnormal flow, perhaps across these valves have a tendency to become stenotic, or the process, or sort of similar sort of processes that developed in patients normally with the normal degenerative aortic stenosis process. Well, they develop earlier, and these patients may develop aortic stenosis and develop with symptoms up to 10 to 20 decades earlier than a patient who develops with a normal kind of aortic stenosis. And maybe I can answer that question about, I think there was a question about the audience of somebody had a 95-year-old father who developed aortic stenosis, and now she is wondering, should I be checked? Could this be congenital? Well, the fact that you develop aortic stenosis in your 90s, that is something that you could just attribute to the normal degenerative aortic stenosis that occurs in older people. And so I don't think that unless you're symptomatic that you need any kind of a screening test. If, however, you belong in the category, let's say your father has developed aortic stenosis in his 50s, and you were told that perhaps your father had a bicuspid aortic valve, and by 65 he underwent some sort of a procedure. Well, in that sort of a situation, maybe you can ask your internal medicine doctor to examine you, to evaluate for any kind of a murmur, which may be indicative of aortic stenosis, and then the internal medicine doctor can perhaps refer you to a cardiologist.
And I think that is so critical, what you just said there, Robert, is that if you have a family member who has a history of valve disease, going into your doctor and letting them know that you do have that family history, and making sure that the doctor listens very attentively to your heart, and or then gets an echocardiogram, which is nothing more than an ultrasound of the heart, can pick up different types of valve problems much earlier, and allow some medical treatment to occur before you need to actually intervene. Robert, you recently opened up a new multi-purpose catheterization lab that's capable of doing replacing valves and also opening up arteries. Would you mind sharing with our listeners a little bit about that laboratory, and why having an advanced laboratory can make a difference both in the opening of arteries and also in the replacement of valves?
Right. Much of what we do percutaneously, that is non-invasively, whether it's opening up an artery with stents or fixing a valve, particularly aortic valve, for example, without surgery, it involves visualization. Visualization is very, very important. And one of the major advantages of the new laboratory, it has the state-of-the-art visualization abilities. Now, the downside of visualization is that it uses ionizing radiation. Uses radiation. You have to see through the body to be able to see what you're doing in a patient's heart specifically. And the new equipment that we have has really state-of-the-art technology that enhances evaluation while at the same time reducing the radiation that is required to produce those phenomenal images. Um, Henry or Dr. Tannous said that it's a heart team approach. And I think this is very important that a laboratory is designed from the onset to accommodate a heart team sort of approach. So you could have a very, very complex patient that requires anesthesia. Well, this laboratory has anesthesia hookup built into the room. I mean, this is more reminiscent of an OR than an interventional laboratory, but we have it in the interventional laboratory. So you could have anesthesia people in there. It's a very large room, so it can now accommodate multiple teams. So I could have a interventional cardiologist, which could be me, and I could have my colleagues working with me, like Pooja Parikh, Gan Hen, Dr. Lawson, J.P. Riley. I could have any one of these people helping me with the intervention. And then if it seems like that we need help because a patient is critically sick and we need to enlist the help of Dr. Tannous to put a patient on a heart support device because that would allow us to proceed with the patient more safely, well, this room can accommodate that group of specialists as well. So, I mean, and
So
this
that's
is
yeah,
only a couple of things.
yeah. So that sounds great, Robert. And if you can just give us an idea, in that room with you while you're doing that valve replacement, it's you. It's all who else? Who are the other main players who are there? Who are the other high-end types of players in terms of their roles in the room? You mentioned anesthesiology. Is
Yes.
there also a surgeon there?
Yes. So it would be an anesthesiologist. It would be, the groups of people that we mentioned in this program is anesthesiologist. It's the cardiothoracic surgeons. It's the interventional cardiologists. And sometimes, oftentimes we have outside the room observing non-invasive cardiologists, the heart failure doctors, for example, who sort of, is following along the procedure that's going inside the room, and we get numbers, hemodynamic numbers, numbers that sort of give clues to how well the heart is functioning or not functioning, and we ask their opinion. One thing that's very, very important, it's not about just the doctors. It's also the support team that's in there. It's our radiation technologist. It's our cath lab nurses. It's our nurse practitioners who are all involved in helping to support that complex procedure that's going on inside. So it's not just the doctors. We have a whole support staff that's
And it's all
also
and
in
yeah,
there.
and also the imagers are a critical component of that. If it's
That's
okay
correct.
with you, we're going to actually show you a little video of that room. So, for any of you who have been in the room, it is absolutely state of the art, and it really, really gives our patients an enormous advantage. Lower radiation, enhanced imaging, space for multiple different individuals of different specialties to be able to participate in the overall care of each of the patients that we have coming into the room. I'm going down some of the questions, and I can see that there's a whole bunch of questions about COVID. And even though it's not the main part of this, I just want to kind of let you know, everybody, go get your vaccine. They're safe. As far as the implications of COVID on the heart, there is a suggestion that there is some inflammation that occurs with the heart. You can have that checked out. So far, nothing long-term that leads to very bad outcomes. So returning back to the discussion at hand, Dr. Rashba, you also are kind of benefiting from the state-of-the-art lab transformations that are taking place. Would you kind of mind moving through what a state-of-the-art lab means in terms of having electrophysiology procedures done?
Sure. So the lab you were discussing before is multifunctional, meaning that there can be interventional cardiology as well as electrophysiology procedures done there. Actually, last week we did a few procedures to close the left atrial appendage using a device called Watchman to help prevent stroke with atrial fibrillation. So we have a multidisciplinary team that participates in those procedures. There's electrophysiology, interventional cardiology, as well as echocardiography all at the same time. And we did those cases in the new lab, and it was much, I would say, much better imaging, as Robert alluded to, enabling us to see what we need to see. And also, I think just the layout of the room makes it much better for these combined procedures with multiple specialties. In terms of what a state-of-the-art, specifically EP lab looks like, so we use fluoroscopy, but our goal is to never step on the pedal when we can avoid it. And
when you say fluoroscopy, you mean X-rays?
X-ray, yes. So the most common procedures that we do, as we talked about before, are ablation procedures, particularly for atrial fibrillation. So one of my colleagues, Roger Fan, has really pushed the envelope on doing those procedures without actually any X-ray whatsoever. So we have 3D mapping systems that we use where we can, it's really like GPS, we can make kind of a shell of the heart chambers that we work in, and we can see our catheters, the wires that we use to map out things. We can see them within the heart on these 3D mapping systems without any X-ray whatsoever. So that's, a major advance. So 10 years ago, that used to be all X-ray. We'd be doing X-ray throughout a whole procedure for an hour or more. Now, most of us, it's, very low dose X-ray. So we use very low dose settings. And if some of us don't even need it at all. So that's, I would say what state-of-the-art for ablation looks like. You also have
if before you jump off of ablation, if I can ask you, so I'm a patient who's been told that I have a rhythm problem in my heart. Are there certain medications that I'm on that would let me know that the bottom part of my heart is having bad rhythms? And if I continue to have symptoms, is that when I consider an ablation?
So, medications that would let you know that there's a problem with the bottom part of the heart, not necessarily, I guess. The arrhythmias that come from the bottom part of the heart can be just single skip beats, PVCs, premature ventricular contractions. We talked about before a little bit where people tend to feel the pause after an early beat more than the early beat itself. So you may just feel kind of a sensation of skip beats. Some people don't feel them at all. Some people feel every single one of them, and it drives them crazy. We usually try medications first, like beta blockers, sometimes antiarrhythmic medications, ablation if it seems like the medications aren't working, or if the skip beats are frequent enough, they can actually affect the strength of the heart muscle contraction. So getting rid of them becomes more important.
Yeah, and so what I was alluding to is, when I see patients a lot, they're on medications called amiodarone or mexiletine, or they're on a medication that somebody has told them is a powerful medication to control the rhythm of their heart. And those seem to be the ones that I send over to you, and you take a look at them, and you can tell which ones of those patients might benefit from getting rid of those bad rhythms completely.
So those medications can be used for multiple purposes. So amiodarone is the strongest antiarrhythmic medication, but it does have side effects. It can affect the liver, the lungs, the thyroid, even the eye. It's used for the most dangerous heart rhythms. So called ventricular tachycardia that can cause fainting or worst case even a sudden death. That's a people who tend to be on amiodarone for that indication have generally a heart muscle problem, so there are people in your clinic. But amiodarone is also used for atrial fibrillation as well. Mexilatine is generally just used for ventricular arrhythmias, so arrhythmias from the bottom chamber of the heart, either single skip beats or sustained rapid rhythms from the bottom chamber of the heart. In terms of when they need ablation, it's either if the medication doesn't work, if they're having side effects, or, I mean, those are the two main things. If it's not working, if they're having side effects, or if there is evidence of heart muscle damage from an arrhythmia that's not completely controlled.
All right. So switching back over, or back, there's a question about heart valves. And so, Henry, does every heart valve that requires surgery need to be replaced, or can some of them be repaired? And is there a difference in terms of the doctor that you go to see, what they're going to decide to do with that valve?
Okay, so that's a common question. When it relates to the aortic valve, the majority of the treatment centers around replacement because those valves are usually very calcified and the quality of the tissues that you have to work with doesn't last when you try to repair them. When it comes to the mitral valve, it's almost 180 degrees because the majority of the mitral valve that we work on, we end up repairing unless the valve is involved with a severe infection, that's what we call endocarditis, or when the valve is involved with rheumatic disease, which in the United States we see less than the rest of the world. So for mitral valve, yes, we repair. For aortic valve, we replace.
All right. So I see a couple of questions about coronary CT and the presence of calcium. Doing a bunch of general cardiology, what I can say to you is that we're defining a new class of patients. You know, in the past, if you had a family history, you had a whole bunch of cholesterol floating around in your bloodstream, and you had other risk factors. The way we would go ahead and kind of risk stratify you would be to send you off for a stress test, and sometimes even a stress test that involved radioactivity to try and see how the blood is flowing through those arteries. What has become increasingly more accepted is to go ahead and do a CAT scan that takes literally 20 or 30 seconds. That CAT scan actually can pick up whether or not your arteries are letting calcium into them. And the logic is that if your arteries are letting calcium into them, they'll also let a huge amount of cholesterol in there that potentially can cause blockages. So we use the coronary CT or the calcium scan in order to be able to figure out whether or not we should be more aggressively medicating you. But when it's come to having symptoms and you are having chest pain or shortness of breath with exertion, that's when we start doing a little bit more intensive imaging to try and see if you potentially could have a blockage. I don't know if there's anything else that you'd like to add, Dr. Pio?
Yeah, I agree that cardiac CT is becoming more available, and certainly if you get sent for a cardiac CT and there's evidence of calcium in your coronary arteries. Calcium in the coronary arteries is what we call pathognomonic of plaque. Calcium doesn't belong in the coronary arteries, as Dr. Skopicki was saying. I mean, that is a pathologic process. So the fact that you have calcium in your arteries means that the process of buildup of atherosclerotic plaque has already started. And then depending upon your symptoms, the question really becomes, have those blockages progressed to the point that it is causing inhibition of blood flow to your coronary arteries and to cause angina? Or is this just a signal that now you must be treated very, very aggressively to prevent these lesions from getting worse? And it's very important that you maintain a relationship with a cardiologist who can follow you up on a regular basis to make sure that everything that can be controlled is optimally controlled.
Okay. And I think one of the things that we're proud of at Stony Brook is that we aggressively manage our patients and try and give them the dietary and the dietary and exercise changes that they need to be employing to best make that cholesterol buildup go away or else slow its progression, and don't necessarily reach for medicines or interventions when others might. There's a question by one of our listeners asking, should high cardiac calcium scores be repeated in the future? And I'll take that by saying that we really don't do that. What we're doing is if we find out that your artery can put cholesterol in there, then we go ultra aggressive at managing that. And because we know that your arteries forevermore will be more susceptible to the cholesterol going in. And then we watch for the appearance of symptoms. Dr. Rashba, one of the listeners asked, can pacemakers control both slow heart rates and fast heart rates? And if not, why are we putting pacemakers in people who do have fast heart rates?
So it's predominantly for slow heart rates. Sometimes the word pacemaker is used to refer to both pacemakers and defibrillators. So a defibrillator is a combined device that can act as a pacemaker, so prevent slow heart rhythms. But if someone has a dangerous rapid heart rhythm, it can be stopped painlessly by pacing the heart, by speeding up the heartbeat a little faster than the arrhythmia. That can often stop it. Or the device can deliver a shock to shock the rhythm back to normal. But the pacing part of that of defibrillators can terminate or stop arrhythmias painlessly. Sometimes for people who have totally uncontrollable atrial fibrillation, maybe we've tried to ablate the focus of AFib, or maybe the patient has too much going on to tolerate trying to go after the source of the AFib. We would put a pacemaker in, but as part of a combined procedure where we also ablate the AV node, the connection between the upper and lower chamber of the heart. That prevents the heart from racing, so we're solving the fast heart rhythm problem, but you need the pacemaker because then the patient after that is dependent on the pacemaker for controlling the normal heartbeat.
There's a couple of questions in there about heart failure, and I think we'll save those for another podcast in the coming weeks. Suffice to say, though, if you're being told that you do have heart failure, that usually means that the heart is unable to pump enough blood in the forward direction to provide for the needs of your heart and of your body, excuse me, and that the blood that's not coming out backs up and can cause water to form in your lungs and make breathing difficult. And those are serious conditions that require proper therapy. I'll also point out that at Stony Brook, one of the advantages of being part of an academic medical center is that we get to put together groups of teams, doctors, nurses, nutritionists, exercise physiologists, people that are all devoted around different diseases and disease states. So we have a sports cardiology program. We have a program that's dedicated to women who are pregnant or are thinking about becoming pregnant, who might have underlying heart disease and want to know how to best manage their pregnancy and their heart simultaneously. We have a center that's devoted to people who have received chemotherapy and to understand its effects on the heart and how, by managing the heart most effectively, they can continue on with their chemotherapy. So I know that the hour is late and we're kind of coming up on the end, but I wanted to give each of our panelists the opportunity to say something about their own personal lives in terms of what they do to kind of prevent heart disease from happening in themselves. So why don't we start off with Robert?
I think that with respect to heart disease, specifically coronary artery disease, I think the best treatment is prevention. Again, if speed or timing is very, very important. once you become symptomatic, I truly believe that you are in advanced stages. Your body has used up all its compensatory mechanisms, and that's why you become symptomatic. So, what I do is that I exercise. I think exercise is very important. It has side effects such as keeping weight loss, keeping weight gain rather in control. It raises your HDL. Exercise is important. Being very conscious of what you eat is extremely important. I mean, as you age, I think your metabolic process goes down, and we just don't metabolize our dietary intake as well as we did when we were much younger. So, that is very important. And also keeping the levels of stress down, which is very, very important. I think exercise contributes to that. Maybe if it's not exercise, maybe it's reading a book, listening to music. I think stress is not good for cardiac heart disease. It's not good for many other disease processes. And mostly, we can go to a physician, yes, to check um, how we're doing. But I think, very importantly, I think you know your body best. You know when you feel good. If there are, if you have symptoms or you feel like something is just off, you don't necessarily have to go to a cardiologist or to a specialist, but I think it's important that you go to your internal medicine doctor. And I do that too. I mean, particularly when you're in your 40s and 50s, you've never gone to a doctor before. Well, maybe now it's time to go to your internal medicine doctor to get your cholesterol checked, to get your blood pressure checked, to make sure that there are not, you know, disease processes that are starting but you're just not symptomatic from it because it's in the early stages, and this is the time that you need to catch it so that you
Yeah,
can treatment.
it's absolutely critical, and I think that what Robert is saying that he personally does. I've tried to call him while he's out on his bike ride or doing his exercise, and as far as managing his stress. That's what Robert looks like when he's stressed, when he's relaxed. He is the calmest person in a cath lab you're ever going to meet. Eric, what do you do to keep your heart as healthy as possible?
Well, over time, I changed my diet. I mean, as doctors, we probably don't really emphasize this enough with our patients, so we just tell them eat a heart healthy diet, whatever that means. But over time, I've kind of eliminated meat from my diet. I'm a vegetarian now. I have fish occasionally, but I found that was very helpful in terms of just feeling better and weight loss without really trying to lose weight. Really, I mean, you'd be surprised how much dense calories there are in meat, and and if we're talking about avoiding high cholesterol, coronary heart disease, I mean we know where it comes from meat and dairy. And exercise. So I agree with Robert. Exercise is very important. So I like to do a lot of yoga. That helps me.
So stress relaxation and making sure that that inflammation that's in your body that we experience so much from processed foods really is kept in check. I think you're right that is the future of how we're going to be approaching our patients from a dietary point of view. Henry, in all of your free time?
I'm glad you asked that question today because last night I got home at 8 and I got on the bike for 20 minutes. But I try to do that often, but it doesn't really happen in real life. Managing stress, as everybody else mentioned, we live in a very stressful world, I would say. Keeping an eye on your weight, on what you eat, not arguing with your wife, I guess. But in general, I would like to also end this with a positive note. I would like to tell all Suffolk County residents and all our patients, if you do come to Stony Brook, you will get the safest and from the simple to the complex procedures. Our cath lab constantly is doing complex procedures, knowing they have surgical backup on site. In case an escalation of care is needed, there's a surgeon inside the building, and not everybody can say that around Suffolk County. This offers our patient a huge advantage, and if other patients were ever told in other places it cannot be done, it might be worth looking into a second opinion here.
Yeah, so that's actually a great plug. I think everybody and every institution runs around talking about how wonderful their program is and the advantages that they have, and we kind of look to our statistics, and our statistics have shown over the last 5 years that we're one of the top 100 hospitals in the entire United States for outcomes, and that outcome is survival. And that comes through hard work and paying attention and having multiple doctors who are smart and committed taking care of you. State-of-the-art technology is something that we pride ourselves on, always looking for the latest, best way to manage a person's disease. And doing that preventative cardiology becomes critical. I know that we had a bunch of questions that we're not able to get to, and I hope you would go visit the Stony Brook University Medical Center or the Heart Institute's webpage here at Stony Brook, where you can find a lot of those answers, and also have a portal to be able to kind of send some questions in and be directed to physicians who may be able to answer those questions for you. I can't begin to thank you enough for taking time out of your day to join us. And we really, really do hope that you continue to educate yourself, your loved ones, and make sure that you're paying attention to your heart health all year round. From the very young to the very old, establishing those kind of interventions, lifestyle, as you've heard all of our doctors, in terms of nutrition, exercise, and making sure that if you identify a problem, you get it taken care of. All of those things are critical. And on behalf of Stony Brook, whether it's that prevention that you're looking for, or a second opinion where we might be able to dramatically change the way somebody is looking at your disease, all the way to having state-of-the-art people and equipment to be able to deliver outstanding care, we're here to serve you. So with that, I want to thank our panelists, Dr. Robert Pio, Dr. Henry Tannous, and also Dr. Eric Rashba for their time, and let you know that they're always here and available for you. Thank you all.